All right. So I will present two cases, quite short. These are two cases that we managed recently in HRPZ2 Kota Baru. And then initially symptoms improved, and after 2 days, and subsequently he had persistent dry cough and started to feel unwell. So we did NP and OP swab for him, and since COVID-19 was detected on 19th of March. He was then admitted about 2 days after that. That was day 7 of illness. And this was his first chest X-ray, which was reported as very minimal changes at right lower perihilar region. And this was his temperature chart. So upon admission, he was afebrile, but about 24 hours after that, he started to have low-grade fever and had a lingering fever of 38 for a few days. His CRP was less than 5 on admission. Platelet was 268 and absolute lymphocyte count was 1.9. So he was started on hydroxychloroquine, and with the chest X-ray changes was later on added on Calitra. And because of persistent fever and also rising CRP, and he was diabetic, so we were concerned of superimposed bacterial infection, so was added on IV Rocephin on day 9 of illness. However, later he had, initially his saturation remains good. However, on day 12 of admission, his fever was more persistent, and he became hypoxic, initially only requiring Nesoprong, but then later on he needs Ventimas. And at this point of time, his CRP went up to 124, and also absolute lymphocyte count is slowly reducing to 1.2, and we did PCT was less than 0.1. Ferritin slowly climbed up to from 700, more than 700 to 875. And the chest X-ray had only slight worsening. It was reported by, anyway, it was reported by radiologists by no active infection, but we thought that there was slight worsening from compared to the previous chest X-ray. And so when CRP went up to 124, we started him on IV dexamethasone 4 mg stat. Dr. Suraj was smiling there because I called him at 5 a.m. and so and he was added on subcut interferon, and he was transferred to ICU as he progressively become hypoxic. So I think after 24 hours, his oxygenation improves. He was on intermittent awake pronation while in ICU, and oxygenation improves tremendously especially on awake pronation. And fever settles, and currently on Nesoprong oxygen only 2 liters. And today we are transferring him out from ICU after 4 days of ICU admission. So this is the CRP trend. CRP climbed from 124 to 138, and after that it actually reduced to 38, and you can see that the ferritin went up to 1,300, and then it slowly came down. Sorry. So we had another case. This is a rather younger man, no premorbid, referred from our COVID hospital, Hospital Tumpat. Category 4A at day 12 of illness, already on Calitra and hydroxychloroquine and also antibiotics, and was noted to be tachypneic. The first chest X-ray on day 7 of illness as shown, and this was the X-ray when he was referred to us 2 days ago. And the ABG shows PCO2 of 40, PO2 of 76. So upon arrival, was changed to 40% Ventimas, was referred to NS, CRP went up from 56 to 65. He also had thrombocytopenia, and raised ferritin of 900, PCT was low. and was started on subacute interferon 1 alpha. We don't have beta anymore. Dexamethasone was given stat, and by yesterday ABG improved very much. He is now only on nesoprong in ICU and shows improvement. So I think that's all for me. Whether I don't proceed with the notes, the learning points first. Then we listen to the case, or we want to discuss the case.
Finish off, lah, Anila. Just finish off. What do you have?
Okay. All right. Stop share. Oh, finish off. What did you say? This will finish off. Oh, finish off. Okay. Dah ingatkan suruh stop. Sekejap. Wait. Okay, so referring to this, whether we were talking about anti-inflammatory, role of anti-inflammatory in patient with COVID pneumonia and those who develop cytokine storm. So the role of steroid is referring to this, if we see in EMRIC critical care, role, whether there is low dose role of low dose steroid for patients with ARDS. So this is based on this Wu et al. Studies, a retrospective study looking at 200 patients with COVID-19 pneumonia, and they look at whether this patient develop ARDS, and they also look at death among patients with ARDS. And what they conclude is that the use of metapred among patients with COVID-19 and ARDS showed reduced mortality. And their comment was typically steroid is used in the sickest patient, hence will create bias towards seeing this patient had a worse outcome when treated with steroids. But then looking at the reduced mortality, probably steroid has some roles in causing benefit in terms of those who has early ARDS in the patients that I presented just now. So and in China, they use methylprednisolone, 40 to 80 mg, but there are equivalent doses of dexamethasone is 7 to 15 mg daily. Hence, that is why we tried 4 mg BD, which is equivalent to 8 mg daily in this case, as because of less fluid retention, since DEXA has less mineralocorticoid activity. So this is they showed this overall survival probability in this study to show the possible benefit of using methylprednisolone. And in this study, what the risk factor for developing ARDS, probably these are the case that we want to consider starting on low dose steroids early. The one with older age showed some organ and coagulation dysfunction, higher LDH, D-dimer, and also high fever. So probably these are those patients that we are looking at and had progressive pneumonia before they actually develop full-blown ARDS. And the article also mentioned about, the website also mentioned about moderate dose steroids for patients with refractory cytokine storm, and they suggested a higher dose of steroids if needed. So I think this is just to illustrate why DEXA is probably preferred compared to methylprednisolone, because of the anti-inflammatory effect and also less sodium retention. I think that's all from us.
Thanks, Anila. So how are you ready, or Yasmin present first?
You can go first, yeah.
Okay, fine.
24-48 hours lah, tapi cepat lah, kena cepat kan. Itulah, kita tak ikut orang lagi, 3 hari dah tak ikut orang.
Yeah, yeah. So I have 3 cases that we want to share. We have the additional benefit of actually having the IL-6 levels, but the IL-6 levels were actually gotten quite later into the management of the disease. Obviously, we took it at a different time frame, so it wasn't real time that we had the IL-6 level. So case 1, I just summarized it a little bit. Extremely high IL-6 levels. This was the initial time where we practiced a more sequential addition of the antivirals, and this is a case that actually clinically improved without any steroids or tocilizumab. So this is a 43-year-old hypertensive, day 7 of illness, had some cough, shortness of breath, category 4B on presentation. So category 4B means pneumonia requiring oxygen. He was febrile, quite a lethargic, miserable looking chap. Vitals, his hemodynamically was always stable. Saturations were 94% on room air. Already had lung findings of fine crepitations. So his baseline CRP was about 4, white cell count 6.9, platelet 172. Total bilirubin was actually normal, liver was normal. This was the time where we only added Kaletra. It was earlier on in the outbreak process. So sorry. So at day 9 of illness, and this was day 3 of antivirals, single antiviral Kaletra, still he was not any better. High spiking temperature, was extremely lethargic. The saturations began to worsen. It was 91% on room air. Lungs worsening finding. The X-ray also looks worse. This time we actually added interferons for him. So he was on Kaletra day 3 and started interferon 1 jab. They rapidly deteriorate. This is something that we see within 12 hours they get intubated. So increased oxygen support to high flow mass, and then subsequently he was actually intubated and then he was transferred to ICU. CRP continued to rise from 4, it went up to 6.9. His absolute lymphocyte count was actually was normal, actually more than 1 when he came in, but it started to drop during this phase of the illness.
The CRP value is a bit different. Huh?
Yeah.
6.94 means for most of you it is 69.4.
So I just summarized this, and I know there's a lot of one here, but we had, he was in ICU the whole time. On the 13th, he was transferred to ICU. As you can see, his ventilatory requirement earlier was actually quite high. But subsequently, his PF ratio started to improve, and he was eventually on CPAP. Now, on the day that we had actually taken the IL-6 level, it's there in red on the 12th. Obviously, we didn't have it at real time, but it's okay. So his IL-6 was actually 331, but obviously we didn't get this result until much later at this red box here. So when we got, when he continued to improve with the antivirals and the supportive therapy that they had, we also saw that there was a lag behind in the CRP. The CRP continues to go up, and then later on only it came down in the later part of the disease. But he was intubated for over a week plus. He was intubated over a week plus, and by the time we got the IL-6 level back, he was afebrile, he was doing much better, he was already extubated. Although with high CRP, he continued to improve, and he was transferred out to the ward. The only effect of the IL-6 that we saw, the cytokine storm that we saw, was he was actually slightly delirious. He was delirious in the ward, but it promptly settled very fast, promptly settled within a day or two, and then he was just recently discharged. He was actually quite well upon discharge. So he was lucid, off oxygen, and you can see his X-ray was very much better. The only effect here was prolonged intubation for about 7 days. That's about it. So the next case is again, that was a younger person. So this is an extremely, again, very high IL-6 level. This guy actually had the highest IL-6 levels. He was elderly with comorbids. Again, this time we actually started combination antivirals very promptly, but he clinically improved without any steroids, but obviously he led to a more prolonged ventilation. So it's a diabetic, chronic kidney disease. He was one of the tablik cluster PY that later on became positive. Initially presented to another hospital, hypoxic pneumonia. So he was category 4B on presentation. He was intubated on so he came in with a bit of uncontrolled diabetes. DXT was high, he had metabolic acidosis, but blood ketones were not so he wasn't labeled as DKA, required oxygen, and then he progressively became, and progressively, rapidly, the PF ratio actually dropped to about 96. So early intubation, they intubate very early over here, but he was very ill on presentation, and post-intubation, we actually started him on Calitra and interferons on day 1 itself. Right? So on day 4 of illness, it was day 2 of antivirals. So his intubated PF ratio was 161 and then dropped to about 140. So his PF ratio actually took some time. In the chart I'm to show you, he actually took some time in order to improve. Promptly, a lot of our comorbids, I don't know if you all see the same thing, they develop a lot of renal impairment that seems to affect the kidneys. But this guy already had CKD to start off with. So he was on inotropes, low support, however. Now, this gentleman, we never started hydroxychloroquine because ECG, the QT was prolonged. Even when we corrected his potassium and all the electrolytes, QT was always prolonged. So we actually never started any hydroxychloroquine for him. And he was prone for lung recruitment, and he was obviously given some antibiotics as well. Now, if you look at this, his PF ratio took a long time to get better. Never had fever. This gentleman never had fever. Inotrope requirements quickly came off, and his total BLE did go up before it started coming down, you know. And many a times he was subjected to a lot of antibiotics. But however, our serial cultures that we sent, there was never any growth. So we thought this was all due to just the virus itself. Now, his CPAP, so he was able to be weaned down to about CPAP, and then subsequently he was extubated. But he was intubated for over 2 weeks. He was intubated for quite some time. And his CRP levels did peak, but after a while it started coming down. Today's CRP is about 7 for him. We also see that procalcitonin starts going up in these patients, and it seems to mirror the peak of the disease. And many a time we think it's a bacterial illness, but again, all their cultures are actually sterile. He also had very high, he also had markers which were actually suggestive of CRS, high ferritin, high D-dimer, high fibrinogen levels. But the CRS level was actually extremely high. 442 apparently is one of the highest that we had in our cohort, and this was taken during this time. And you can see he wasn't on any inotrope support. Ventilatory settings were low, but PF ratio was always about 140. Our ICU does believe that it causes some degree of pulmonary fibrosis, some mimicking pulmonary fibrosis. So they don't aim for a very high saturations, and they seem to avoid high CO2 in these patients. So they do keep them at a much lower PF ratio, but with lung recruitment, they seem to come off. The PF ratio did improve, and then leading to extubation. And this was the, so day 3 was like that, day 6 it was like this, and day 13. Although the the chest x-rays doesn't show very extensive disease, I'm sure you can appreciate that there are ground glass, peripheral ground glass over here. This is, again, high IL-6. This guy, we actually gave tocilizumab. Day 1, a 60-year-old, obesity, age, he actually had elderly age, he is hypertensive. Came in day 8 of illness. He was intubated as SpO2, nasoprom was 92%, and like I said, they actually progressed very fast. He was febrile, lungs had bibasal crepitations, white cell count, ALC is low, platelet was low, CRP was already 10. Renal function was normal. He had mild hepatitis, and HRCT actually already showed ground glass appearance. So this person, we actually started on Calitra and hydroxychloroquine for when on admission itself, and covered him with some antibiotics. Day 9 of illness, he got intubated because unable to sustain saturation and a high flow mask. At this point, PF ratio dropped to its lowest, which is about 180, continued to spike the temperature. Was intubated, And at this point, the CRP from 10 is now actually went up to 15, at low absolute lymphocyte count, high NLR ratio, and added interferons on day 9 of illness. Again, hydroxychloroquine, we were starting and stopping because of prolonged QT. At day 10 of illness, so this giving tocilizumab is probably at day 10 of illness, his ventilator setting did go down, right? But PF ratio was maintaining about 150 to 180. BP started dropping, and he was actually supported with noradrenaline. And they thought there was some, because procalcitonin was slightly on the high side, thought there was infection going on. But again, all the cultures were actually of no growth. ALC continues to drop, CRP continues to go up, and he started developing multi-organ failures as well with increasing inotrope support. We insisted on restarting back the hydroxychloroquine because after correcting the PF ratio became the QT interval was no longer seen, prolonged QT was no longer seen, so we restarted hydroxychloroquine. But the next day 14 to 15 of illness, on day 7 to 8 of antivirals, fever began to settle, but there was worsening of PF ratio, worsening AKI, increasing inotropic support, and on top of it, we already had cultures that showed that was sterile. This time, procalcitonin was low, total bili was high. Again, he was started on CVVH. We did, the day before, we actually sent for ferritin and fibrinogen and D-dimers, which are all raised. And we had the benefit of having the IL-6 level the day before. And this showed a very high IL-6 level, and we actually started him on tocilizumab. Added a dose of Dexa because at this point didn't know whether we could only get it for one patient. So we didn't know whether we can repeat it again or not. So we started tocilizumab as well as Dexa at the same time and continued to antivirals. Day 17 of illness, day 10 of antivirals, day 3 of tocilizumab, the patient starts to improve. Actually, the very next day, the patient actually started to improve. We were able to bring down the saturations, weaned off the inotropes. Dialysis, the kidney takes time for it to get better. Most patients, we see that in most patients. CRP, the maxima, I think it went up to 30, and then it started coming down. Ferritin also started coming down, and fibrinogen started coming down as well. We weaned off and stopped the Dexa fast. I think we only gave it for about 4 days, and then we weaned off the Dexa, and he was actually aiming to extubate. But because we give tocilizumab and Dexa, we are doing surveillance cultures for him weekly. Today he's actually on nasal prong, and I found out he was more stable. So this is basically so what we did was we got about 20 patients with IL-6 levels. So each of this plotting is actually a serial finding, a serial plotting of CRPs as well as lymphocyte counts, as well as temperature, total bilirubin in patients who had high IL-6 and low IL-6. Each line here represents one patient. The others, there were other things that we looked at as well, but these are the ones that seem to have a significant change, a significant difference between those patients who had high IL-6 and low IL-6. The grossly what we can see is the CRP rise in these patients. The CRP rise in these patients seems to be more rapid in those who actually had high IL-6, whereas in low IL-6 we didn't see that. Absolute lymphocyte count for most patients started to drop, whereas it seems very variable in those who had low IL-6. Difficult to see because the plotting of the temperature, the graph, the scale of the temperature is a bit different here, but a lot of patients did have some, but I think there's not much significant difference, but a lot of patients did have higher temperature readings with those on cytokine storm. And what is more obvious is the total bilirubin did start going up in those patients who actually had a high IL-6 compared to one over here in the ones with low IL-6s. That's all I have actually.
Can I just make a comment? So this graph actually, the NIH group, sorry, the NIH group helped us do this, but none of it is significant because only 20 patients left. So this graph sort of tells us what to look out for so that they can do a bigger study. And so we think this graph sort of tells us.
We can barely hear you.
Okay. Sorry, the slides, these numbers are not significant because there's only 20 patients. And so what the graph shows is something that we should probably look out for in high IL-6 patients. None of them actually clinically significant difference. The visual imaging shows that, increasing CRP, decreasing lymphocyte count, higher temperature, and increasing bilirubin could be markers of high IL-6, at least later in the disease, because as you can see, these patients were actually quite late in the disease in ICU by the time we did all the IL-6 levels. That's it.
Okay, Sazan.
How UM's turn?
Hello?
Yep.
Hello, hi. Good afternoon. So we are sharing our experience with using of tocilizumab here. So our first case is Mr. WWS. He's a 66-year-old gentleman with underlying diabetes, hypertension, and dyslipidemia, and also history of international travel. So he was presented, first symptoms started on 15 March with sore throat, cough, and shortness of breath on exertion, but there's no fever. In view of the risk factor, he went to our emergency and done swab in which positive, thus admitted next day. Although hemoglobin stable, saturation is good, but the chest X-ray showed numeric changes. With the comorbid, we started him on hydroxychloroquine, also with isoflurane and also azithromycin. However, next day, his condition deteriorated, in which he complained of worsening shortness of breath. This deteriorated, thus we referred to ICU and admitted to ICU. We also started on Caletra and changed azithromycin to doxycycline. So despite of his condition, treatment started, his condition is continue worsening, oxygenation is not much improvement, chest X-ray is worsening. I will show later the result. And thus we started tocilizumab. And next day, when after tocilizumab started, his condition dramatically improved. So this is the chest X-ray in which he was initially presented in West Test consolidation over the right lower zone. His condition next day is deteriorated and just admitted to ICU. So despite in ICU, despite on prone position and negative balance, his condition is not improving, and we even planning to intubate him. This is the X-ray on the day 10 of illness, in which showed worsening, chest X-ray changes, and also inflammatory also increasing. So that's why we started tocilizumab. Next day, his condition is improving. This is the trend. So he was admitted on day 6, in which during that time he's still on oxygen, room air, not requiring oxygen. With baseline CRP is 88. So when his condition is deteriorated initially, the CRP is coming up to 119, and the lymphocyte count slightly dropped. So despite on high flow nasal cannula, the oxygenation is not much improved. Chest X-ray also worsening. That's why we started tocilizumab. Next day, his condition also improving by PF ratios. Also, we showed this improvement, and yeah, the CRP also coming down after that to 64 about day 2 of tocilizumab infusion. So we also have other patients. So the second patient is Mr. JSD, 55 years old, diabetic, was presented at day 7 of illness with fever and in history of international traveling and meetings. So on arrival, he's tachypneic with respiratory rate of 28 and requiring oxygen supplementation with post-crepitation of bilateral lungs up to mid-zone, right more than left zone. So he was admitted to ICU, started on hydroxychloroquine and Caletra. Despite of that, ferritin is rising with decreasing lymphocyte and poor oxygenation. That's why we added on subcut interferons. He had continuous spike temperature despite upgrading antibiotic to tazocine, vancomycin, and withholding interferon and persistent hypoxia. Thus, we started tocilizumab at day 14 of illness. So this is when the patient was admitted, has spiked temperature with baseline CRP 84. So his condition is continued worsening with rising CRP. We added interferon, but there no much improvement. CRP even coming up, and also oxidation also not much improvement. That's why we started tocilizumab, and subsequently his condition is improving. We're able to wean off the oxygen to nasal prong, and the CRP bit static with ferritin also a bit same. Our next patient is Mr. MS, 69 years old gentleman with diabetes and hypertension, was initially admitted at day 6 of illness with fever, cough, and poor oral intake, with risk factor of family gathering with close contact with public cohort. He was initially well for the first 2 days in ward, but however, deteriorated later, developed respiratory distress in which required intubation. He also developed acute kidney injury and myocarditis, thus transferred to ICU. Later, the PCRs came back positive for COVID-19, and we started hydroxychloroquine and Kaletra. So this is the patient condition when he was admitted. The CRP, the lymphocyte is still okay. The CRP is 110, in which he deteriorated about 2 days later. CRP is coming up. Then despite of that, next day we started tocilizumab, then hydroxychloroquine, and also Kaletra stopped because of prolonged QTC. Although the CRP is improving, oxidation also improving, but he developed hospital-acquired infection, pneumothorax, and also subcutaneous emphysema. So biochemically, it's improving, but clinically, it's not much improvement because of the hospital-acquired infection and also other complications. Our next patient is 48 years old gentleman with hypertension and morbid obesity, presented at day 7 of illness with productive cough and worsening shortness of breath and also diarrhea. There's no apparent risk factors, but swab done a day before was positive. Upon arrival, he was in respiratory distress, thus intubated in ED. He also has cardiomyopathy with ejection fraction of 30%, raised cardiac enzyme. We started hydroxychloroquine and also tocilizumab on the admission. So we started treatment on admission, in which oxygenation is improving. We managed to wean off to CPAP. The CRP is coming down, and then he's extubated on about 4 days later. Our next patient is Mr. SSS, 59 years old gentleman, who presented also at day 7 of illness with cough, fever, and shortness of breath. So he initially was quite okay with the pneumonia changes. We started hydroxychloroquine and also Kaletra, but next day he's hypoxic and increasing oxygen requirement with saturation set to 8. Thus, he admitted to ICU and started tocilizumab. So the fever subsided 1 day after started tocilizumab. The oxygenation also improved with PF ratio, and we changed to nasal prong after 2 days given tocilizumab. CRP also coming down nicely. Our last patient is Mr. MAB, 66 years old gentleman with diabetes and also hypertension, presented at day 8 of illness with fever, cough, shortness of breath, and confusion. He's a cleaner in masjid. On arrival, his hypoxic respiratory failure with saturation 60%, 67% on room air, thus intubated. So the PCR came out to be positive, and we started hydroxychloroquine and also tocilizumab on the admission. Oxygenation improving after started tocilizumab next day, but it's still early. We didn't see changes in CRP yet. Otherwise, he's still intubated. Today is day 4 of admission.